case, as well as tuberculosis. It's very rare to see tuberculosis patient, but you have to know how to diagnose this. Do you have questions about polio? Okay, we continue with the next disease. It is obstetric paralysis. This is a paralysis of the upper limb obtained after the birth. And there is a damage of the plexus brachialis, which will disturb the growth, and this causes significant disability to individual which is affected of obstetrical paralysis. Actually, obstetrical paralysis is a iatrogenic disease. Iatrogenic means caused by doctors. The Greek students know what does it mean. Iatrogenic, iatros. Okay, at the time of birth, if there is a trauma of plexus brachialis from abnormal lateral flexion of the head, it is possible to develop, to start obstetrical paralysis. Actually, it happens sometimes when there is a breach and at the course of the delivery, first it comes the body of the baby, and then it comes the head. You know that the head is the biggest part of the fetus, and it comes a little bit hard, and the delivery became difficult. There is a special maneuver for delivery, and this maneuver consists from significant lateral flexion of the body, of the neck region, and this will affect or stretch the brachial plexus. What is clinical presentation? After the birth, there is a rapid development of paralysis of one limb, one upper limb, not both, not lower limb, one upper limb. Asymmetry of movements. Affected limb is lying on the couch, and normal limb is moving spontaneously. After that, usually parents and doctors could observe developmental delay and, of course, impaired function. This is a motor function and sensory function together, because the trauma is actually disturbance of nerve roads of the brachial plexus. Both motor and sensory involvement will be present in those cases. Obstetric paralysis could be separated in three forms. Proximal paralysis, type ERP, which has the reason of this paralysis is stretch or involvement of C5 and C6 nerve roots of plexus brachialis. Then paralysis type Klumpke or distal paralysis, which affects C8 to Th1, B1 nerve roots. And finally, and hopefully very rare, a global paralysis, which affects a whole brachial plexus. But some investigators divide cases and presentation of brachial plexus injuries in more extended classification, which comes from Narakas. This classification divides the cases in 4 groups. First, upper ERPS group, which affects C5, C6. This will affect shoulder abduction, internal rotation, elbow flexion also sometimes affected. Usually those cases has a good prognosis, and it consists from 80% of cases. The extended ERPS palsy will affect more roots, C5, C6, C7, and it causes a wrist drop. Usually it is compared to a global affection of the brachial plexus. Sometimes, if the trauma is like neuropraxia, has a spontaneous recovery, but some cases between 10 to 30% will not recover, and it is very important to be recognized by investigation, by some examination. And those cases should be treated properly. Total palsy is divided in 2 groups, with Horner or without Horner syndrome. You know what is Horner syndrome? It is more often addressed to the upper involvement, and it consists from meiosis, ptosis, and of Town. Horner syndrome. The cases with Horner syndromes has a worse prognosis without surgery, and this will cause disability to whole limb function. Anyway, the treatment of paralysis. Sorry, before this, the clinics. Usually, ERP paralysis involve the muscles of the shoulder. There is no active abduction of the shoulder. The shoulder joint is in abduction contracture and internal rotation, because the muscles of the scapula are completely flaccid. There is a funny compare of this position of the hand. In some books, I met the symptom of waiter's tip. The hand is faced back with adducted limb, and it looks like one waiter is waiting for a tip. But the function of the hand is completely spared. Only the function of the shoulder is affected. This is proximal paralysis, ERP type. The Klumpke type affects lower part of the brachial plexus, and it usually has involvement of biceps and also forearm muscles. The hand is usually flexed and inactive. It's very, very hard to be treated. And the global paralysis is almost equal to amputation because there is no function in any joints, in any muscles in the affected limb. Treatment of proximal paralysis R type consists from treatment of early stage after the birth, because the disease is presented even in the first day after the birth. The treatment starts with the positional treatment. Usually, the affected limb should be kept in the flexed position of the elbow, abducted position in the shoulder, and it could be kept by application of the splint. This position will decrease a stretch of the neural structures, and this will work beneficial to the stretched nerves for a long period of time. This position should be kept for at least 40 days or longer. And after that, we could perform some examination to find out what is the degree of trauma. Usually, the most effective examination is electromyography, and this electrophysiological examination will give us information if the degree of trauma is neuropraxy or neurotmesis, or even worse, neurotmesis. After that, at 3 months of age, we could decide what treatment should be proper for this kid. If there is a spontaneous recovery of the motor and sensory function, it's okay. The treatment will continue with medicaments and physiotherapy. But if there is no recovery, the proper treatment will be neurosurgery. Neurosurgery. By this way, we could restore the torn or divided neural structures by suturing. At the late stage, after the paralysis is presented, it comes time for reconstructive surgery. Reconstructive surgery could be addressed to regain the abduction and external rotation of the shoulder. Usually, it's addressed to orthopedic surgeons. We could perform muscle transposition. For example, latissimus dorsi could be transferred to perform external rotation, and this will help the hand to be again in the front of the body to react normally. What else? We could perform corrective osteotomy of the humerus with the same goal to place the hand in the front of the body. 30-degree, we usually cut the bone. We usually cut the upper part of the humerus, perform transversal osteotomy, and then distal part of the bone should be rotated in 30-degree, externally rotated. After that, we make osteosynthesis, and this will transfer the hand in more useful position. Reconstructive surgery. Paralysis of Klumpke, it's very difficult to be treated, but the treatment is same. Conservative treatment for the period of 40 to 60 days after the birth by immobilization. And after that, neurophysiological examination to classify the spread of involvement. And then neurosurgery, if it is possible. It's microneurosurgery, which is not conventional, not conventional for every hospital. There should be a special trained neurosurgeon to perform this type of surgery. There are several techniques which could be used: neurotization or nerve transfer with some grafts, some local grafts or distant grafts, neural grafts, which will help to regain the neurotization of affected muscles. Global palsy, it is the most difficult to be treated. Usually, the period of immobilization doesn't improve the condition of the patient. And after that, we could observe the retardation or the slow development of all limb, and a long period of observing this patient, we could see that this limb is completely disabled and it's equal to amputation. Hopefully, only 10 to 30% of all patients affected with obstetrical paralysis should be treated by surgery. All the others have some spontaneous or medicamental improvement of the condition. Do you have questions according obstetrical paralysis? Okay. The next disease which I'll talk about is spinal muscular atrophy, which has additional name Charcot-Marie-Tooth. This is a genetic disease at all. It affects whole familia. And in Bulgaria, there are several places where we have a local spread of this disease, mainly in gypsy familia. Actually, this disease is autosomal dominant, has as autosomal dominant transmission, and it is more common in boys, but sometimes affect and the girls. Um, the development of the disease affects symmetrically both limbs, lower limbs and upper limbs together, and it spreads from peripheral to the central parts of the body. In a late stage, uh, it affects a spinal cord. The disease starts from the childhood, and with the growing of the kid, it affects additionally muscle groups from distal to proximal. This is the reason to stand this appearance of the patient suffering from Charcot-Marie tooth muscular atrophy. When the disease affects the gluteal muscles, it is impossible for the patient to walk alone. That's why those patients usually are affixed to the wheelchair. Clinically, at the beginning of the disease, there is a loss of sensation for vibrations. Then it starts to develop a peripheral muscle atrophy, which affects first hands and feet, short muscles of the hands and feet. Then there is affection or spread to the forearms and up lower legs. Then it comes time for hips and gluteal muscles. The treatment. First, before treatment, the diagnosis. The diagnosis is made by electrophysiological examination, by testing of affected muscles, and also by family history, because as I said before, this is familiar disease, genetic disease. Treatment of the affected individuals could be performed by tenoelongation or tenoabbreviation, teno shortening of the tendon, with the only goal to stabilize the affected joints. For example, starting with the ankle joints, then to the wrist joint, we have to stabilize those joints to spare the function. Then sometimes we need to perform muscle transposition. And then finally, we could help the patient with performing arthrodesis. As we know that this disease has a progressive course, that's why arthrodesis is the final decision for stabilization of affected joints. Usually, those patients are you can see those patients in the city centers or in the cross of the street, like being like beggars, because they cannot work. They only can beg some coins. Next disease is progressive muscular dystrophy, Duchenne, or as it short known as DMD, Duchenne muscular dystrophy. This is a very sad disease. It affects X chromosome, and it appears mutation of gain for for fabrication of one protein dystrophin. This protein dystrophin is indispensable for transmission of neural signals in neurons. That's why this gain mutation it's very bad case that could not be treated. Usually, not usually, but in every case, this mutation affects only boys, and it's carried by the woman because it's located in X chromosome, and it is a recessive inheritance. The transmission is from mother to son. Sons are always affected, and they are affected from progressive muscular dystrophy, but mothers are only transmitters. Girls in the same familia are not suffering from this disease, but they are transmitters. This genetic disease begins in preschool period, for example, 5-6 years, and it has a progressive and unfortunately fatal end up to 10 to 15 years of age. It's very sad that nobody can help those kids. Pathogenesis, as I said, there is a lack of synthesis of dystrophin, a special protein which leads to the lack of this protein leads to muscle weakness, and the replacement of the muscle tissue with adipose and fibrous tissue, it makes our muscles inactive, and unfortunately it has progressive involvement to the limbs and pelvis muscles and trunk muscles, heart, and it's usually symmetric involvement. It starts in early childhood, it ends in the puberty. Clinical appearance of Duchenne muscular dystrophy consists from easy fatigue to affected individuals, difficulty in getting up from sitting position or in lying position. It's typical to climb over the body when the kid is trying to stand up. It's typical also to observe a pseudo-hypertrophy of affected muscles in thigh muscles, in calf muscles. It looks very strong and massive, but they are weak, and actually they cannot perform a muscle contracture. Additionally, it appears contractures in almost every joints. Laboratory presentation consists from elevated CPK, aldolase is elevated, also alanine transaminase is elevated. When there is some doubt, it's good to perform biopsy, and on a biopsy usually could be observed a muscular dystrophy with a lot of fat tissue developed in the muscle tissue. EMG changes are also typical, and they are uninvasive way to find the diagnosis. Also, familiar history and genetic consultation is also helpful to find out the diagnosis. Actually, there are many types of Duchenne muscle dystrophy, but all of them are impossible to be treated at this time. This slide presents a typical way of standing from sitting position. According to muscle weakness, kid is usually has some needs of support, upper limbs to the hips, the pelvis, and it usually has a rapid fatigue when it walk, or usually the kids do not want to play with their friends because of this rapid fatigue. Treatment is not possible. Etiological treatment is not possible. The only way is to help those patients to be supported and to be and the support also deserve the parents, because they have to care about those kids, and it's not easy, because the disease getting worse with the growing of the kid. Again, all boys are affected in certain family. It means genetic consultation should be a good idea for the parents with the history of Duchenne dystrophy in their families. And if there is a prenatal diagnostics for a boy, it's better to perform how to say, abortion. And final subject of those neurological diseases for this evening is peripheral nerve compression syndromes. They're caused by a temporary or permanent compression of peripheral nerves by internal pressure, swelling, or some volume process, or external pressure in physiologically narrow spaces. There are several physiological narrow spaces at the course of the natural course of peripheral nerves that we are they are well known, and we have to ask, we have to look for them if we diagnosed a peripheral nerve compression. Usually, nerve compression is manifested by paresthesia or muscle weakness, or even paralysis in the area corresponding to a certain peripheral nerve. The most common appearance of peripheral nerve compression syndrome is carpal tunnel syndrome. This condition involves the median nerve at the region of the wrist. The reason for carpal tunnel syndrome could be different. For example, volume process like tumors, benign or malignant tumors in this area, some vascular diseases, some tenosynovitis at the carpal region could be the reason for carpal tunnel syndrome. Also, ganglion close to the carpal tunnel could be presented with carpal tunnel syndrome or compression nerve syndrome. Sometimes articular disease, degenerative articular disease could narrow the space for median nerve, and it's very interesting to find out the real reason for this carpal tunnel syndrome. Clinically, the syndrome is presented by paresthesia at the region of spread of median nerve. As you know, maybe the autonomical zone of median nerve is a sensation of the pulp of the index finger. We have to check the sensation of the tip of the index fingers in both hands, and usually in carpal tunnel syndrome there is a paresthesia or anesthesia or hypoesthesia in this area. Additionally, there could be presented with motor neuron dysfunction, which will result in tenor hypertrophy, flattening of the tenor muscles we observe usually. The grip strength suffers, and usually patient explain that they experience night pain, feeling of burning or some other improper sensation in the region of median nerve. Sometimes it affects, this syndrome affects an ulnar nerve because it comes in the ulnar part of the canal. We call this Guion canal. And we have to distinguish the involvement of ulnar nerve and median nerve. The other clinical symptoms which are typical to this condition is Tinel symptom of Tinel. Symptom of Tinel should be checked by knocking over the compressed nerve, and the patient reports that it feels like sense of the electricity when we knock over the carpal tunnel, patient reports pain and a sense of electricity. It comes because it comes like that because when there is a long time compression of the nerve, the sheets of the nerve became thinner, and the neural signal will cross some bands, and this will provoke a strange sensation like electricity. There are several other symptoms, could be elicited with examination of the patient with carpal tunnel syndrome, but the tunnel symptom is the most famous, most continuous to the condition of the patient. The important examination which will approve the compression of certain peripheral nerve is EMG, electromyography, and this is the mandatory examination before starting any treatment of compressive syndrome. Actually, the treatment is decompression. Decompression could be performed by medicaments, local and general, and if it doesn't improve the condition, local condition of the involved hand, there is time for surgery, surgical exploration of affected nerve, review of the right reason for compression, and permanent decompression by cutting the palmar carpal ligament. This ligament keeps the space when the median nerve is compressed. When cutting this ligament, we decompress all the carpal tunnels, and the median nerve became decompressed. In some neglected cases, which has a long history of compression, we usually observe thin and compressed nerve like sound watch, and in those cases we perform neurolysis. Neurolysis is a longitudinal dissection of the nerve and excision of sclerotic tissue, sclerotic sheet. This will help the nerve to become again healthy. First operation is decompression, and in severe cases with long history of compression, when we observe not shortening but thinning of the nerve, we perform neurolysis. The other location is ulnar paralysis. Ulnar nerve usually is compressed in canalis nervi ulnaris at the elbow region, but sometimes is compressed in the canalis of Guillaume. The clinic is different because the affected muscles are different, but the sensory region is the same. That's why in all cases, when there is affected ulnar nerve, we have to perform careful examination to find out where is the true compression. The compression could be distally in Guillaume canal, then proximally to the fascia of the forearm, then in canalis nervi ulnaris at the back side, back medial side of the elbow, then proximally again in the fascia transition. It's usually 5 to 6 centimeters up to the medial epicondyle of the humerus. We call this Stratter's fibers, which could compress the ulnar nerve. And the most proximal part of site of compression could be at the foramina intervertebralis because of appearance of disc herniation or some accessory ribs or some case of Scalenus syndrome. This will cause also paralysis of ulnar nerve. That's why neurophysiological examination is mandatory in every case of peripheral nerve syndrome. This examination will detect the actual site of compression. Paralysis of radial nerve. We could observe those paralysis when the radial nerve is compressed in axilla. Sometimes patients which use crutches, and if they use improper way crutches, will experience a radial nerve palsy because of compression of radial nerve in axilla region. The other reason for compression, or the other site of compression of radial nerve, is in canalis humeromuscularis because of some volume spread process or muscle hypertrophy or some repeat trauma in this area. After that, it comes distally canalis supinatorius, where the radial nerve is divided in two branches, superficial and deep branch. If there is a hypertrophy or edema in this area, the deep branch will suffer with the symptoms of peripheral nerve compression. Thoracic outlet syndrome is actually presentation of compression at the site of scalenus space between musculus scalenus anterior and musculus scalenus medius. This is a place of natural course of plexus brachialis. There are several symptoms which be provoked with the abduction and external rotation of the hand, affected hand. We could observe slowing or absence of radial pulse, because together with the brachial plexus, it comes subclavius artery, and this will increase this position of the hand, will increase the compression, and together with this, the hand will become numb. Thoracic outlet syndrome is typical for sportsmen because of muscle hypertrophy, but also in those individuals which have additional ribs, how to say, sorry. In lower legs, we also could observe peripheral nerve compression, starting with the compression of sciatic nerve at the buttock region. When in the slim patient use uncomfortable chair, and the sciatic nerve could be compressed, and the symptoms are the same: numbness of the limb, pain in the course of the nerve, also paresthesia, and muscle weakness. Tarsal tunnel syndrome. Tarsal tunnel syndrome comes when there is a compression of a tibialis nerve, and the clinical appearance is a pain, a spread of the pain to the front of the foot, and it is diagnosed better with electrophysiological EMG. Mortal metatarsalgia is the most distal appearance of compression nerve syndrome. This is because of compression of interdigital nerves, usually in the space between second and third toes, most often in women, which walks with the high heels shoes. And the clinics of Morton disease is sharp pain and burning pain at the end of the day, which is spread to the front part of the foot. Typically, the pain will increase when we press at this point between in the web space between second and third toes. Diagnosis is usually clinically stated, and the treatment is most effectively performed by steroid injection, which reveals symptoms in a few days, and there is no necessary for surgery for surgical decompression. But if we talk about the compression of the physiologically narrow places, or compression by the volume spread process, usually there is necessity of surgical treatment. Okay, I think that's enough for this evening. If you have some questions according those diseases, I'm here to answer you. Of course, I will load the presentation. I want to thank you for your patience and understanding. We had many obstacles according to virus